Right, thank you very much for inviting me here. Again, another whistle-stop tour of what we've been able to achieve in Scotland. What I want to do is just to briefly go through that. It's a totally different system again. It's rather like Wales. We don't have commissioning. We have health boards, which you can see on here. We have 11 mainland health boards and some island health boards, but the majority of what we're talking about today is to do with the mainland ones. We started thinking about hepatitis C quite a long time ago in Scotland. It was really about 2000 where we actually, there was what we call a SNAP report, which is Scottish Needs Assessment Programme. We actually highlighted that there was going to be a big issue with hepatitis C. And the Scottish Viral Hepatitis Group, on the background of that, managed to persuade the government to start taking note. We had a consensus conference, which is really very similar to what we see here today in front of us, where we actually managed to persuade the government that there was quite a pressing need, and they recognised this as being one of the the greatest public health challenges facing Scotland. About the same time as that conference, we also set up the guideline, the SIGN Guideline Development Group, and that was produced in 2006. And that was a evidence-based guideline, the Scottish Intercollegiate Guidelines Network, and that produced really the background on what we should be looking for in terms of how we set up an action plan in Scotland. From then on, the government were really behind us. From 2006 to 2008, we had what we call the phase 1 of the action plan. And that was really 41 separate pieces of evidence were gathered to inform, to say what the existing services were and how they were being set up, and also to look at the needs assessment of the vulnerable groups that we're looking to treat, and to see how we could actually then develop this into a phase 2, which is what we're currently in. So it's really work in progress at the moment from a phase 2. And what they did is they set aside 34 individual actions which we had to perform on. They were monitored, and what I'm going to do is just give you a very quick flash through some of these actions and where we are with them at the moment. You've seen this data related to England and Wales. The Scottish data is really identical. This is the end-stage liver disease. You can look at hepatocellular carcinoma. You can look at the first-time hospital admissions, the hospital bed days, the number of people going to transplant, the number of people dying, and the graphs are all the same. They're going upwards at a fast rate. And so it was realised that we had to do something about it. We also realised that we have 50,000 people estimated from prevalence studies to actually be antibody positive, with just under 40,000 chronic with PCR positivity in Scotland. And out of those, we only know about 40% of them on our epidemiological work. This is again before the action plan kicks off properly. This is in 2008, before we actually start trying to make a difference to this. We see that in one year, in 2008, that only 22% of those who actually knew about were actually being engaged with the service. And out of those, only 16% of them were into treatment, only 500 being treated. So there was a big gap. There's a lot of lost positives in there, which we needed to find and start treating as well. There's a lot of modelling went on, a lot of predictive modelling was done in this first phase, and I think the Health Protection Scotland felt that this was the clincher which made the government sit and take note. And if we look at these three graphs, this is the number of people you treat per year with antiviral therapy, and if you can get to 2,000 people being treated per year, then you see that the annual number of liver failures, or it could be bed days, whatever way you want to look at it, that starts levelling off and starts dropping. So there's no doubt that if you reach a certain number of people being treated, you can actually start making an impact onto the epidemic. So just to briefly go through the three different elements of the action plan. The first was to prevent the actual spread of the virus, particularly amongst the active drug using population. We also have, if we look at our drug in Scotland, about 90% of people with hepatitis C have either been active or are previous drug users. And we know that there's about 24,000 of people who are ex-drug users and about 9,000 who are actually are active drug using. So the second part is really to identify those who are positive, particularly in the groups where they've moved on beyond the treatment services in terms of their addiction issues. And they are the ones who probably have the disease for longest and most need to benefit. We also want to ensure that those people who are going forward for treatment are actually going to receive the optimal care and support. So this is what they decided to do, is that over the 3 years of the phase 2, they put aside £43 million. And what they did is they ring-fenced this into certain points. The 8 million were for prevention initiatives. There was about just under 30 million was for testing, treatment, care and support. And that's not just the drug costs, it was the setting up the services, setting up the networks. And then 6.5 million was for the national coordination, the database, the information generation and gathering public awareness and education programs. And I think what they appreciated from the first phase of the action plan, as we've heard all through this morning, is that data is king. And if you know what you're doing and you can measure it, you can actually make a really compelling case to continue doing what you think is right or to change what you've got wrong. So to go through each of these one at a time: prevention, the issues we'd identified, widespread variations in injection equipment provision, sharing of the equipment was very common. And the actions, and these are the action points as they evidenced in the programme. We set up proper guidelines which are going to be universal across Scotland, and we actually improve and make sure that everyone's using the same sort of equipment services. And the actual performance indicators was going to be annual surveys of the prevalence and incidence amongst active drug users, and those, and also proportion of those who are actually using equipment or reusing equipment, and all those, and to do this on an annual basis, so we can actually see, are we making a difference with what we do. When we actually look at what's happened over the last 15 years in Scotland, there's not a lot of hard data out there which shows that actually harm reduction makes a difference to actually the actual rate of hepatitis C or the prevalence of hepatitis C. But here we can see that in different regions we're seeing a different effect. And what was interesting when you look in the 1990s, that Tayside and Lothian had a really bad time with HIV, and I think it was a lot more harm reduction issues and harm reduction services were put into those than into Glasgow, which didn't have that much HIV. And as you can see, that Glasgow remained at a rate of about 70 to 80% positivity for on the anonymised testing. And this is the latest snapshot. This again is part of its annual surveys we're doing, and it's showing that Greater Glasgow is running at about 73%, my own area, Forth Valley is running at about 53–55%, and the East Coast, which are the lighter colours, are slightly less, between 30 to 40%. And now we're starting to collect data on the needle exchanges, and we're seeing that actually, when you look at the bottom, Greater Glasgow and Clyde, they've got nearly 9,000 active users, and they are on balance per year, they're only exchanging 120 needles per year, whereas at the top in Fireford, Dumfries and Galloway, you're getting up to 400 needle exchanges per year per individual. So this is important data, and this is what the action plan will generate as we go through the next couple of years. So the achievements are, we've now gone through a process of deciding how the kits should be put together, been approved by our Lord Advocate, and no matter where you go in Scotland, you're going to get the same sterile kit of the same sort of paraphernalia with it. And the education side of things, we're making sure that everybody knows that there's going to be a lot more leaflets, a lot more media sent out to schools, to universities, to talk all about harm reduction and prevention. For testing and diagnosis, the issues were